Hello, everybody. Welcome to all our guests in the chat. Thank you for taking some time to join us today for this session on getting dementia ready, tools and tactics for healthcare providers. Very excited to host this conversation with you all, to receive your questions. As we were kind of chatting about quickly before getting started, this is a really top of mind topic for a lot of healthcare providers. So glad to be with you all here today. Give you a bit of an introduction to our format. You'll be hearing from our featured speakers, who you can see here. We'll host a discussion on preparing for an increased demand in dementia screening and care. We're going to have a dedicated time for Q&A at the end of the session. We'll give that about 10 minutes or so. So please feel free to leave your questions. There's a questions tab at the bottom right of your screen. We'll do our best to address as many of those questions as possible during that Q&A time. And we also like to follow up with any questions that we don't get to and try to answer those. And the session is being recorded. So for those of you who are here, you'll receive the recording afterwards. And for our registrants, we'll make sure that they receive it too. So an introduction to Creyos. Creyos is a tool for precision cognitive assessment backed by over 30 years of research. Creyos has been helping healthcare providers worldwide more confidently evaluate patient cognition, mental wellness, and behavioral health. Founded by the world-renowned neuroscientist we have here with us, Professor Adrian Owen, began as digitized tests for scientific research, has grown into an organization dedicated to improving clinical decision-making when it comes to brain health. The platform has been used in over 400 peer-reviewed studies and by thousands of clinicians worldwide. With a normative database of over 85,000 participants, Creyos is uniquely positioned to help healthcare providers more objectively evaluate and treat cognitive and behavioral health conditions, leading to better patient outcomes. And we're also really excited today to talk about the clinical applications of dementia screening and care, and as well as using these cognitive assessment tools. So let's get an introduction to our speakers today. Adrian, I'll get started with yourself.
Yeah, hi there, everybody. My name's Adrian Owen. One job I have is as a professor of cognitive neuroscience and imaging at the University of Western Ontario in London, in Canada. But I am the chief scientific officer at Creyos. I'm one of the co-founders. I originally devised the test back in beginning in the late 1980s when I was doing my PhD back in the UK.
Thanks so much. Dr. Hunt, can I turn it over to you next?
Yes, of course. Hi, everyone. Justin Hunt. I'm the Senior Medical Director for Behavioral Health at Oak Street Health. Oak Street is a collection of largely upfront capitated primary care centers that we're up to about 205 centers across 26 states, and I help provide the medical leadership for the implementation of the collaborative care model across all those centers, which is a model of integrated behavioral health and primary care. And we certainly think about dementia a lot in our setting.
Thank you. And Melissa?
Hi, my name is Melissa Piccioni. I'm a registered nurse working at UConn Neurology under Dr. David McCoy. We've been utilizing neurocognitive testing for 10 years now, and with Creyos being the most recent in the past 5 years, I believe it's been. So it's a great tool in helping our patients.
Amazing. Thank you all so much for joining us today for this discussion. I also want to point participants to the polls tab at the bottom right of your screen as well. Just as we're kicking off this conversation, feel free to leave your response to that first question on which topics that we're going to be covering today are you most looking forward to hearing about. We're going to be talking about understanding the gaps in dementia detection, strategies for improving provider-patient relationships, how to create operational efficiency, and if there's anything else, please feel free to write your questions in the questions tab too. So to get us started, we know today it's, I think, pretty well-known knowledge that there is this systemic gap in dementia screening and care. today, about 40% of the individuals in the United States with dementia receive a formal diagnosis. So there's work to be done on closing that gap. But to get started, why do we think this systemic gap has been there? And Adrian, I'm wondering if you can get us started by speaking about the research perspective on our understanding of the brain and age-related decline and cognitive decline.
Sure. Yeah. Thanks, Sonia. Well, I mean, I think the reason the gap exists from a neuroscience perspective is that until relatively recently, we just didn't have the tools to accurately and reliably measure small changes in cognitive performance. I mean, when you think about things like detection of dementia, the most commonly widely used tools are things like the mini mental state and the MoCA, the Montreal Cognitive Assessment. And I mean, these tools are fine at the extremes. If you have a patient who is really doing very poorly on a MoCA or an MMSE, obviously you know they have a problem and you need to do something about it. If you have a patient that's scoring error-free or delivering error-free performance on either of those tools, similarly, you know that they're cognitively in good shape. But of course, we know that most people fall between those two extremes, and many of them will fall around about the so-called cutoffs. And in those cases, it's very difficult to really know whether a patient is impaired or is not impaired. And of course, this extends to following patients longitudinally as well. I mean, these tools, the more traditional assessment tools, won't develop to follow patients longitudinally. They're not sensitive to very small changes. So you really would have to monitor a patient over a very long period of time often to be able to detect a change if it was there. And by then, you've passed the point at which it would have been better to go on to further assessment or to implement some kind of therapeutic strategy. So for me, that's been the biggest change, and that's the reason for this gap, is that we've simply not had the tools available to make these assessments when and where we need them.
Thanks so much. And from the clinical perspective, Melissa, I'm wondering if you could kick us off speaking about what this gap has looked like in practice with patients.
Really, from the patient perspective, they think, well, what can be done about it? Is a lot of times when they come to see us, they be like, yeah, maybe I have a memory issue, but they don't think anything can be done about it. But tools such as Creyos can tell us exactly what areas there are deficiencies. And then we also dive deeper into what is causing those. Could it be something metabolic? Could it be something, perhaps like a depression disorder that affects a lot of people, and they don't realize that then too affects their cognition. And so really, they're either terrified that they're going to be told there's something wrong and nothing be done about it, or be something wrong and then they feel like they lost a lot of independence as well.
Mm-hmm, mm-hmm. And Dr. Hunt, what does that gap and patient experience look like in your experience?
Yeah, so it's certainly a challenge in primary care. We know that approximately 50% of patients with cognitive impairment are undiagnosed in primary care, and that number is likely higher in kind of a classic FQHC or community health center setting, and in our centers are very much like that. And we really at Oak Street see it as a health equity issue, because we also know that people of color often have higher rates of dementia, and then they're also going undiagnosed as well in the U.S. Healthcare system. And we feel that much of this, Dr. Owen summed up the challenges with the current tools. We have traditionally used the mini-cog and slums in our screening process, and we are now in the midst of launching Creyos, and we're so excited about that, because we need a more rigorous and structured way to get at this in our annual wellness review visits that are required by Medicare, because we know that our quality with the mini-cog and slums was lacking some in the past. It's like high variability in the quality of fielding of those instruments. So we're so excited to use Creyos to have a more standardized and rigorous approach, and I think that will help to alleviate the gap some.
Yeah, it sounds like a couple factors at play, like from the research perspective, tools that kind of only detect the most severe cases that aren't equipped for that longitudinal testing, and understanding, like you were saying, Dr. Hunt, as well, about health equity and that this affects different populations differently. And there can be barriers to accessing the healthcare needs. To segue into our next question, to dig a little bit deeper into some of those systemic issues and like operational issues, what are your points of view on how well equipped today the healthcare system is to address this gap? What are some of those friction points that still exist? And Melissa, maybe we can start with you.
I think some of the friction points are having the tools and then understanding how to portray their usefulness to patients. And so really just letting them know that we can do something, getting their trust is really big too. And so having the healthcare system just be prepared to do that. And I think at least with our clinic, I've seen that we do really strive hard to address these issues and then assure patients all over that we care much about them as they do themselves.
Mm-hmm, mm-hmm. Yeah, Dr. Hunt, more thoughts on that?
Yes, I certainly agree with all of that. And in the primary care setting, and primary care, unfortunately, in the United States at least, has been chronically underfunded. So there's often just not enough resources and time to do this as well as we should. And in the Medicare space with these annual wellness review visits, it's remarkable the number of screens that we have to complete during what we call the rooming module at Oak Street. We have to think about depression with the PHQ-2 and PHQ-9, have all sorts of like kind of social determinants questionnaires, and then of course we have to get at cognitive impairment too. So a lot of it comes down to time, and quality, of course, begins to suffer sometimes when MAs are rushed and getting through all the requirements of an annual wellness review visit. I do think trust is so important too, and the trust of both the patients in the process as well as the trust of the providers too. So, and it's been wonderful to have Creyos with the large amount of literature to support it, and kind of making that sell to the providers initially, and then I'm sure we'll have patients ask questions as well.
And Adrian, I know coming from the research side, you have a different perspective or a different kind of vantage point on this, but thoughts on how well equipped today's healthcare system is to address this gap?
Well, I hope better than ever before is my brief answer. I mean, one of the great things about that I've seen as Creyos has evolved over the last 30 years or so is that we've taken technology that was really only available in the research space. It was really only something that went on in the science lab, and we've turned it into something that really can be applied in the clinic. And I completely agree with our other two guests that one of the big problems is making things easy, making them simple, making them easy to use, making them very quick to use, delivering reliable results quickly, and of course cost effectively too is true. And I mean, Creyos didn't begin many years ago when I began to develop the platform back in the UK. The idea wasn't actually to go in this direction. It was to try and to find out how the brain works and how we can best assess the brain and how we can monitor performance on various brain-based tasks. And I think this is a fantastic application. I'm really extremely proud that we've managed to create something that does deliver easily administered, cost-effective solution in the clinic that is still really well grounded in the science. I mean, I think that's the really important thing. We haven't given up on the science. I still use it every day in my lab at Western. As you already said, it's supported now by over 400 peer-reviewed papers. I think we've tested over 14 million We've delivered over 14 million tests over the years. So I think this is a very good application, and frankly, it solves a problem, and I'm very proud of that.
Yeah, so I love that, very hopeful answer about, hopefully better equipped than it ever has been before. And overall, it sounds, there's been this tension between, new evidence and like a really aspirational point of view about how to help patients and some of the time constraints around actually kind of implementing all of those strategies that we want to have in place to build trust and have better health outcomes with patients. So as we work towards improving methods, what can researchers and clinicians do now working together to improve our methods for dementia detection and care? I think I'll pass it over to you first, Dr. Hunt.
So I think going back to the structured approach is very important to us, and we really wanted to help our Oak Street primary care providers understand the exact diagnostic criteria for dementia, and then tying those DSM-5 criteria to the different aspects of the Creyos tool. And Creyos has been a perfect fit for us in many ways, because you of course have the objective and impairment measures with both the kind of the screener and the assessment, but then also importantly to our primary care providers, there's also a questionnaire on functional decline as well, and that of course is required per DSM-5 to move in the dementia direction. And that was a real challenge for us in the past. So like we would have the mini-cog and then the slums. We'd have a score on the slums, and then the providers wouldn't necessarily know what to do with that. And then they were not routinely doing the Lawton-Brody IADL questionnaire to get at functioning. So it was really hard to get to a clear diagnosis. And then, of course, if you don't have a diagnosis, you don't have a clear treatment plan, or you can't have good coaching around lifestyle changes and some of the recommendations there too. So the structure with Creyos was a big attractive point for us, certainly at Oak Street.
Melissa, thoughts from the clinical perspective?
From the clinical perspective, we do appreciate the questionnaires available. We utilize the PHQ-9, the G87, and then also the ASDS. The only thing that really is kind of not reaching all is just like an Epworth sleepiness scale, because sleep disorders contribute to a lot of cognitive issues. And so having that available, we managed to just do it ourselves, pen and paper. But I think if it was just kind of added in, that would be great, because we'd have all the information contained in one file.
So it sounds like from the clinical perspective, one of the methods to improve with dementia detection and care is the sense of like completeness and structure in like what gets tested. Adrian, what about from the research perspective?
My answer to this question is very similar to the last one, really, which is that we've stayed really close to the science to try to work out, what the need is and how can we deliver that need, given the enormous amount of data that we've collected over the last 20, 25 years or so. So, the first thing that, working closely with Oak Street, the first thing that was really obvious is that we need a screener. Everybody cannot go through a full assessment simply to decide that they don't need one. And we worked really hard on the screener, and it was developed by the science team in Creyos, in collaboration with scientists in my lab, using largely data that we already had available to us. We took very large data sets, and initially the idea was to try and work out which test or combination of tests could be delivered and could best identify those patients who really needed to go on and have a more fulsome assessment. And we've ended up with a 2 to 3 minute screener involving just 2 tests. We validated it, but again, with data that we had available to us from patients that had been visiting, had been admitted to a neurological clinic, compared to our extremely large normative database. We identified the test that could best differentiate between those 2 groups of people. And then, of course, once you've you've come up with a solution like this, you've really got to validate it. And we did that in three ways. The way that I was most closely involved with personally was in my own lab. We study patients who have been diagnosed with dementia, and we used the screener to make sure that, or we tweaked the screener, I suppose, to make sure that we could accurately differentiate between those patients and a group of matched elderly controls who weren't demented. We also looked at a large group of patients who had been admitted to a neurological clinic with tags like dementia, cognitive impairment. And again, we were essentially training a machine learning classifier to be able to tell the difference between these two groups of people. And then the final stage, I hope I'm not giving you too much detail there, but the final stage is really to make sure that you get a nice balance between sensitivity and specificity. And what I mean by that is that you want to make sure that you are picking up accurately as many patients who do need a more fulsome assessment as you can. That's sensitivity. But specificity is equally important. That is that you don't test everybody. You've got to find a balance between those two things. And I think we've done it really, we've done it very, very well with the screener. We have high levels of both sensitivity and specificity, identifying really early on who should go on to have the complete assessment and who really for whom people for whom that is would be unnecessary. So I'm very happy with how this has worked out. But again, it has involved a lot of close collaboration with Oak Street to get this right. But I think we're just about there.
Yeah, the clinical really feeds into the research. The research enables the tools for the clinical. It's really, really great to hear more about how that collaboration works. When we are talking about practical applications, so understanding that there's a need for more sensitive screening tools, and also, putting those screening tools into place, as we've kind of touched on. Time is a big constraint. Making sure that you can see all the patients that are expressing this increased need for dementia care. So how would you go about implementing these solutions in your healthcare practice? For others who are thinking of going down a similar path, what would you start with? Melissa, would you kick us off?
Yeah, so actually what we decided to do was to dedicate specific times to the testing, and then also one clinic member to administering those tests. And that way we can give the patients as much time as they need to do it. They won't feel rushed. And then also with our follow-up visits where Dr. McCoy is reviewing the results, he's actually extended those visit times as well, because we realized that there have been so many follow-up questions just after the testing's been completed as to what to do from that point forward.
Mm-hmm. Mm-hmm. Amazing. And Dr. Hunt, what does that look like in practice with Oak Street?
Yeah, so because of our sheer size of over 200 centers, we certainly started out with a piloting approach, and that's where we learned some about the screener and the sensitivity and specificity, and then Creyos has been wonderful to work with us and optimizing the screening, and then of course the further assessments as well, and so it's. We've learned a lot in 2 pilot studies that we did, and 2 Philadelphia-based centers, and we're now rolling it out to kind of beta centers in the Chicago metro area, and continue to learn more. But it's remarkable how much smoother it's going in the beta stage as opposed to the initial pilot stage. And we're going to have to do a lot of training over the next 2 months to train the different care team members that are involved. So, particularly the MAs. So we have like kind of a cascading training plan in place with preceptors, and then train the trainers with our center medical directors, so they can be in a good place to guide their providers as we launch the new tool in July. So it's a pretty complicated operational lift, primarily because of our sheer size at Oak Street and the change from the longstanding Minicog and slums to the new tool.
Mm-hmm, mm-hmm. And Adrian, again, I know you have a different vantage point on this question, but what's your point of view on what's needed to implement technology like this into a healthcare practice?
I think we need to work very closely together, the clinical teams and the research teams at Creyos. And, we love to do this. Right? We recognize that there's no one size fits all. Everybody has different requirements. They have different patient populations. They may be asking actually quite different questions about those patient populations. So as we've done with Oak Street, we really love to work really closely with the clients to get it right. We don't expect that we're necessarily just going to be able to deliver something off the shelf that is immediately going to solve all of their problems. But I do think, and this has been a great example of that we can solve the problems. But it requires a dialogue, and it requires, as Dr. Hunter said, some piloting, working out exactly what needs to be tweaked, where are the questions that really need to be answered, what are the most burning questions, and that requires some back and forth between the clinical and the science teams. And for me, that's actually part of the fun.
Yeah, really exciting to hear how these tools get more and more refined with clinical input. And finally, once these best practices are in place, what are the results that clinicians can expect and start to see? Dr. Hunt, can we start with you?
Yes, absolutely. Well, one of the things we're most excited about is the very clear report. So kind of the output of the Creyos tool is very important to us, because we truly do want to capture the prevalence of dementia in our population. We know that we're probably diagnosing at Oak Street, and we do a pretty good job of diagnosis. Probably about 60% or so of the dementias there we're truly capturing. So we did a lot of thinking, and then of course as we were exploring tools to think about how can we get our providers to be more comfortable with actually making the dementia diagnosis when you have the objective cognitive impairment there, when you have the functional impairment, and then of course also the subjective cognitive decline. And the report we're seeing is very helpful in getting folks there. And then Creyos, you guys have been wonderful partners too, and kind of explaining how this tool works in different populations. So populations with low literacy is a very important group at Oak Street, and how Creyos still remains valid and reliable in those populations as well has been also very helpful to have our providers be more comfortable with diagnosis. I think one challenge that we have in this space still is that we still don't have wonderful treatments, of course, for this progressive illness. Not an excuse not to diagnose it early, because we can certainly implement some healthy lifestyle interventions and things of that nature. But I still think that sometimes is a barrier among some providers. It's almost like kind of this nihilism that exists when it shouldn't. Because I think actually things are looking up in the neuroscience world, and we're learning more and more, and we're certainly heading in the right direction. But that remains a challenge.
Yeah, and Melissa, you touched on this as well. Sometimes patients having that hesitation to kind of embark on that health journey to get these answers. But in your experience, what are some of the results that clinicians can expect from putting these tools in place?
Really just having more and more patients coming in willing to do the cognitive testing, and then can track it, as they feel things worsen, improve, and just they can see their progress either way. And even family members can kind of anticipate then what the needs might be for their loved ones.
Mm-hmm, mm-hmm. Yeah, more communication. It sounds like more engagement. Adrian, what are your thoughts on this?
we know the research has shown that continuity of care is best for patients, but it's also best for clinicians. Patients like it if they sort of have a one-stop shop. They can get everything they need from screening to assessment to longitudinal monitoring. But it's the same for clinics and for clinicians too. If they don't have to farm out the patients to another a neuropsychologist somewhere else, or another type of assessment in a different clinic, everything runs much more smoothly, and the patients are happy and the clinicians are happy. And I'm really glad that that's what we've worked towards, and I think we've delivered it successfully. A single package that can allow screening, full cognitive assessment where it's necessary, and also longitudinal monitoring of patients. And hopefully it keeps everybody happy.
All right, and looking towards the future, and Adrian, I think I'll get you to talk on this first as well. What do you see as the future direction of dementia care and research? Are there any emerging trends or areas of significant promise?
Well, I can tell you what we're looking forward to, Sonia, and I love to talk about the future. For us, it's data. And, the thing about these tools that I think people need to realize is that the more data you put into them, the better they get. This is not something that we're going to pretend is perfect from the outset. We put several, in fact, tens of thousands of data sets went into developing the tool as it exists. I think we're really close. But of course, as more data becomes available, as more patients get assessed and we follow them longitudinally, that data can obviously in a completely anonymized form, it can get put back in to improve the sensitivity, the specificity, and the overall accuracy of the tool. So, I mean, really, this is what I am most looking forward to, is trying to even increase these things even further. And of course, that comes with other advantages. I mean, as you get more data and you feed more data into the tool, then we'll be able to do things like differentiate between different types of dementias. Because we'll have enough patients in different subgroups to be able to maybe tease apart some of the subtle differences that may down the line become important as therapies become available. Maybe it's not so important now, but as different therapies become available in time, they may be more applicable to some subtypes of dementia than others, and it'll be really important to be able to pick up those differences. And again, that's something that I think we're in a really strong position to be able to start to tackle. So that's what I'm really looking forward to.
Amazing, thank you. And Melissa, what is your vantage point on this future opportunity?
I think just having a multifaceted approach to treating dementia, and not just, hopefully it comes out with more treatments, that address all areas of the cognition that need to be improved or fixed, or even just like allowing people to understand how brain, ages and everything in that realm.
A multifaceted approach, that educational piece, understanding the brain more. Yeah. And Dr. Hunt?
Yeah, I was actually really excited to hear Dr. Owen talking about how the increased amount of data, which hopefully Oak Street will help with our population, will help kind of begin to differentiate between the different kinds of dementia too. Like with our current treatment guideline that is in development and is to be approved this week, we're really kind of getting clinicians to kind of the dementia clinical syndrome, which, of course, there are many irreversible causes of dementia that can drive that dementia clinical syndrome. And so we're getting them kind of to an unspecified dementia diagnosis, but we ultimately really want to achieve a great amount of specificity and diagnosis. And that does become hard in primary care, because you're starting to ask a lot of the primary care provider at that point to differentiate between Lewy body versus frontotemporal, or the various kinds of dementia. And then in many of our communities, we just do not have very quick access to neurology expertise. So the more assistance we could provide in primary care, that's certainly very exciting to me. And then of course this implementation of Creyos is driving lots of good thinking at Oak Street about really optimizing our overarching primary care model for dementia patients too, because we really want to be able to catch these folks in a meaningful care model that takes care of them and their caregivers after we place the diagnosis.
Yeah. Thank you all so much. So we're going to take this last few minutes. We have about 5 minutes for questions. So for our participants, again, feel free in the bottom right-hand side of your screen, there's a tab for questions. We do have a first one here. When folks are thinking about not just the workflow implementation, but kind of the business casing for dementia screening and care, and I'll just open the floor, whoever would like to answer. What is your point of view on how cost-effective a solution like this is for a direct care practice, perhaps when they're not factoring in, insurance coverage as well?
Our office actually offers a cash pay price for this for those who are not insured. And with how our practice works and how often we're doing it, we've actually found that we can charge as little as $125 per test administered. And that seems pretty cost effective for our practice.
I can. Our situation's a little bit different because we partner with Medicare Advantage plans, and then we're paid in kind of an upfront capitated manner based on the complexity of our population. So certainly capturing dementia that's truly there through a rigorous screening process is important to us from a financial perspective on the kind of the risk adjustment side of things. But then, perhaps more importantly, from a clinical perspective, accurately diagnosing these folks can really have a big impact on downstream medical costs as well, which is also very important to Oak Street. We say that we want to keep people happy, healthy, and out of the hospital. And folks that have undiagnosed dementia are much more likely to fall and end up in expensive med-surg hospitalizations. And of course, there are multiple other scenarios too. So we see it as a highly cost-effective move from our perspective.
Yeah. Really great to hear both from the patient perspective on making that affordable and accessible, and also thinking about the business case and making that sustainable. We have a question here more from the research perspective as well. What goes into creating a data set in order to achieve that sensitivity in a cognitive screening tool?
Right, that's one for me, I think. Yeah, this is I could talk all day about this, but one of the big advantages for us is that we have been collecting data with the Creyos tool for many, many years now. And in fact, as you've already said, there have been many tens of peer-reviewed publications. So I think unlike many other tools, and I won't pretend that we set out to make this happen in advance, it was just a serendipitous thing, but unlike many other tools, we didn't sort of develop a tool and then say, well, let's take it out into the world and see whether it works. The tools were developed in my lab to answer specific neuroscientific questions about how the brain works and what goes wrong when bits of the brain go wrong. So in that context, we'd already acquired tens of thousands of data sets from different populations. So back in the day, I won't tell you how long ago, but I was testing Alzheimer's and Parkinson's patients back in the early 1990s for my own PhD work on these tests and on versions of these tests, which started already with giving us good clues about, what were good tests and what were good markers within those tests for differentiating between different neurodegenerative conditions. So we had a really, really good starting point, I would say, or a head start. And when we came to developing the tools for more specific applications, like the one we're talking about today, it was really a case of selecting from that database or optimizing from that database which were the specific tests that gave us the most information. And we did that. We were able to do that because, of course, we had many thousands of patients have been tested at this point, and healthy participants have been tested. And from that, it's a fairly straightforward procedure to work out which test or combination of tests is giving you the most valuable information in in colloquial terms, the most bang for your buck, because we could do the entire battery on every person, which will give you a lot of information, but there's also a lot of redundancy in there. There's a lot of information that you don't really need to be able to make a diagnosis or use it as a screener. So we try to find this sort of sweet spot between having enough information to be able to have an accurate screener, but not wasting people's time, either clinicians or patients. So I think we've been very lucky, to be honest. Over the last couple of years, and this is the validation part of it. That was the development. The validation has been to say, okay, now we've got that. We've followed the clues the little crumbs that we've left for ourselves over the years. Now let's validate it. Let's take it and test it in a group of patients who have actually been diagnosed with dementia, and make sure that it can tell the difference between those people and people who haven't. Now let's take it and compare it to a group of people who are presenting at a neurological clinic with signs of cognitive deterioration. Can it tell the difference between those people and people who have no apparent cognitive impairment? So quite a lot of testing is involved, and we're really keen to get this right. And this is, the great thing for me is this can all be done in the context of research. This is all really interesting. These are really interesting research questions for me. The extent to which any tool or combination of tools can or can't tell the difference between different groups of people. So that's really how we got there. A lot of hard work by people that are actually way smarter than I am, but I think we've got there. And yes, it was through really capitalizing on the large data sets that we've acquired over the years enabled us to do this.
And like you said before, it comes back to that feedback loop between being able to get a lot of that patient data, work with healthcare providers, and build that data set. Thanks so much for that insight. That takes us to the end of this conversation. Again, thank you all so much for joining us. We have a couple polls. Please feel free to let us know what topics you'd like to hear from Creyos about in the future. There are a few options there, such as latest advancements in cognitive health research, strategies for patient care and management, preventative medicine topics, streamlining operational efficiency in your practice. And if there are others, please feel free to let us know. And you can also let us know in the poll if you'd like to sign up for our monthly newsletter or speak to one of our product specialists. You can see here places to connect with us. Feel free to reach out to us at www.creyos.com/demo if you'd like to speak to us directly, and follow us on social media. Thank you again so much, all of our wonderful panelists, for this conversation today.
Thank you.
Thank you.
Thanks. Bye.